Welcome to This Explainer. Today, we're diving into some incredible data that is completely reshaping an outdated and honestly pretty harmful stigma. For decades, borderline personality disorder, or BPD, carried this heavy, pessimistic label in the medical world. It was often brushed off as quote-unquote untreatable. But as you'll see, the actual science tells a totally different, incredibly hopeful story. We're going to trace the objective data today, starting all the way from the painful developmental origins of BPD right through to proven hard neurobiological recovery. So if you've ever wondered how the human brain can actually heal from profound emotional dysregulation, you are absolutely in the right place.
Okay, let's dive into this. Here's our roadmap for today. We're starting with number 1, the biosocial roots. Then we'll move into number 2, the big 5 therapies. After that, we'll look at number 3, generalist care for everyone. And we'll wrap up with number 4, rewiring the brain.
Section 1, the biosocial roots.
Now, to really appreciate the power of these treatments, we first got to understand where this profound pain actually comes from. We have to validate the intense emotional dysregulation that people with BPD experience on a daily basis. This isn't just someone being difficult, right? This is genuine, deep pain. And Marsha Linehan's biosocial theory is really the bedrock here. What's so interesting about her theory is how it objectively frames BPD, not as a character flaw, but as a biological sensitivity. It basically posits that BPD arises when a child's inherent biological emotional vulnerability collides with what she calls an invalidating environment. Think of an environment where a child's emotions and basic needs are chronically neglected, ridiculed, or just totally dismissed. The child doesn't just feel bad in the moment, they're actually systematically deprived of the chance to learn healthy emotional coping skills. It's like this tragic perfect storm of biology and environment.
So let's look a little closer at that environmental piece. There's this really compelling study by Jaworska and Drashevska, and it highlights a stark objective contrast when you compare childhood trauma indexes across different severe mood disorders. As you can see, patients with borderline personality disorder have significantly higher indexes of emotional abuse, physical abuse, and neglect when compared to, say, patients with bipolar disorder. Now, while both conditions obviously involve severe mood instability, this data points out just how deeply early childhood trauma factors into the development of BPD. It's a remarkably trauma-heavy history, which honestly explains the sheer severity of the relational and emotional symptoms we see later in life.
Section 2, the big 5 therapies.
All right, here is the really good news. Despite all that historical pessimism we talked about, clinical science has proven that BPD is actually highly treatable. We aren't just talking about managing symptoms so a patient can barely survive. We have a solid array of proven clinical approaches that create real, lasting change. To simplify what can sometimes feel like a massive clinical landscape, we can group the most effective treatments into what we call the big 5 psychotherapies for BPD. Okay, ready? They are dialectical behavior therapy, or DBT, mentalisation-based treatment, NBT, transference-focused psychotherapy, TFP, schema-focused therapy, SFT, and good psychiatric management, or GPM. Now, while these are multi-year therapies that differ pretty wildly in their specific day-to-day techniques, the data clearly shows they all yield incredible, significant gains for patients. You don't just have one single option, you have 5 incredibly well-researched, evidence-based paths to recovery.
And hey, you don't just have to take my word for it. A major research synthesis from the Levy Lab, which is a huge clinical authority in this field, confirms that these active, specialty treatments effectively manage BPD symptoms far, far better than standard care or just sitting on a waiting list. Regardless of their theoretical origin, whether they're cognitive behavioral or psychodynamic, these therapies absolutely work.
So, let's break down how they actually differ, starting with 2 of the most famous ones. Dialectical behavior therapy, developed by Marsha Linehan, is highly structured. It's all about teaching practical, functional skills across very specific modules, things like mindfulness, distress tolerance, and emotion regulation. It's super behavioral and very present-focused. On the flip side of that, you have mentalization-based treatment, or MBT, which is a psychodynamic approach rooted deeply in attachment theory. MBT focuses heavily on helping patients mentalize, which is basically a clinical term for learning how to reflect on and understand your own mental states and the mental states of others, especially when you're under interpersonal stress. Essentially, MBT helps you hit pause and think before reacting when you feel deeply triggered in a relationship.
And this brilliantly illustrates our next 2 approaches, transference-focused psychotherapy and schema-focused therapy. TFP is fascinating because it tackles the fragmented identity that is so unique to BPD. It actively works to integrate those polarized, split representations of self and others, that intense tendency to see people as either completely good or completely bad. SFT, on the other hand, is all about breaking down rigid, maladaptive childhood schemas. These are those deeply held, incredibly negative beliefs that stem directly from unmet needs in childhood. SFT does this through experiential techniques and something called limited reparenting, where the therapist actually steps in safely to meet some of those early developmental emotional deficits. So both of these therapies really dive deep into correcting the core identity and relational wounds of BPD.
Section 3. Generalist care for everyone.
But, okay, here's the big challenge in the real world. Specialized therapies like DBT and TFP are amazing, no doubt, but they literally take years for clinicians to master. There just simply aren't enough trained specialists out there to meet the massive demand. So if we actually want to solve this crisis on a macro level, we absolutely have to look at scalable solutions that everyday practitioners can deploy to reach the masses. Enter Good Psychiatric Management, or GPM. This is a highly scalable approach that empowers primary care doctors, nurse practitioners, and non-therapist mental health professionals to effectively manage BPD. It focuses heavily on the patient's relationship hypersensitivity. It offers super practical case management, and it uses symptom-targeted medication. By giving general medical professionals a structured, evidence-based toolkit, GPM is making life-saving care vastly more accessible to folks who are currently just sitting on endless waitlists. So the crucial point here is captured just beautifully in the simple GPM clinical principle: work before love. What does that actually mean in practice? It means prioritizing the stabilization of a patient's vocational and educational goals before they tackle the highly triggering, emotionally intense realm of romantic relationships. Getting a job, going to school, paying your rent on time, these structures stabilize the patient's time and, crucially, their self-esteem. They create a really necessary emotional buffer, proving that practical day-to-day life management is actually a profound form of therapy all by itself.
Section 4. Rewiring the brain.
Okay, this is where it gets incredibly cool. We're moving from psychological theory to hard, undeniable neurobiological proof. Therapy physically changes the brain. I really want to emphasize that, because this completely and definitively shatters the stigma that BPD is some sort of unchangeable biological life sentence. It's not. We now have the imaging technology to prove that talking, practicing coping skills, and experiencing a safe therapeutic relationship literally, physically alters the brain's structure and function. Let's walk through this neuroimaging data together, because it is mind-blowing. Functional MRI studies show that after completing treatments like DBT, patients exhibit a significant deactivation of the amygdala, which is the brain's emotion and threat center. It literally calms down. There's also reduced hyperreactivity in the anterior cingulate cortex, or ACC. And at the exact same time, we see increased prefrontal activation. That's the area responsible for inhibitory control and rational thought. It's like the brain's brakes getting stronger. We even see altered activity and increased gray matter in the inferior frontal gyrus. So what does this all mean? It means these therapies literally rewire the cortical limbic circuitry. They physically reduce a patient's baseline emotional reactivity and drastically improve their behavioral control. The brain actually heals.
So considering all of that, I want to leave you with this final provocative question. If talk therapy can literally rewire the physical brain, how do we make these life-saving treatments accessible to absolutely everyone who needs them? The data validates immense, undeniable hope, right? BPD is highly treatable, and the brain is remarkably plastic. But the challenge now lies in breaking down those systemic barriers to care. We need to champion scalable solutions like GPM while we continue to fund and train specialists, ensuring that anyone suffering from BPD has a clear, truly accessible path to recovery. Thank you so much for joining me on this explainer. Keep learning and keep asking the big questions.